Hey everyone, welcome back to Part 11. I am absolutely thrilled you're here. Today, we're putting on our auditor hats and stepping into the shoes of an expert clinical documentation improvement specialist. We're going way beyond the textbook today and jumping right into the trenches of real-world clinical validation. In this explainer, we aren't just taking what the physician wrote at face value. We are acting as rigorous clinical investigators. We're going to dive into the raw vitals, the lab results, and nursing notes to verify if those documented diagnoses actually meet clinical criteria and, most importantly, if they can survive an intense payer audit. Let's get into it.
So we're transitioning from the theoretical world of abstract coding guidelines directly into the gritty reality of clinical data. This is literally where the magic happens, folks. We have to bridge that gap between what a provider suspects might be happening and what the objective data actually proves.
Here's our game plan. 1. Clinical validation rules. 2. Sepsis 3 and SOFA scoring. 3. Clinical scenarios and baselines. And 4. CDI queries and audit defense. We're building an ironclad defense against audit denials today.
Starting right off with Section 1, Clinical Validation Rules.
For all the coders and CDI specialists tuning in, you know accurate documentation is a joint effort between you and the healthcare provider. But I really want to anchor our entire discussion on this absolutely crucial mandate from CMS. Clinical evidence should be present in the medical record to support code assignment. That's your golden rule right there. We operate in an era where a doctor's documented word, while highly respected of course, is just not always enough if the raw clinical indicators are missing. If a physician writes sepsis, but the labs and vitals just show a routine localized infection, yeah, payer auditors are going to strike that claim down in a heartbeat.
And this is the reality we face every single day. On one side, you've got the medical record, packed with narrative notes and provider impressions. On the other side, you have the cold, hard, raw coding data. Coding clinic advice heavily stresses the absolute necessity of validating clinical conditions before you do the coding. You are the filter. Code assignment is based on the provider's statement, sure, but when that statement directly contradicts the clinical reality of the chart, well, we have a massive compliance and revenue integrity issue on our hands.
Okay, moving to Section 2, Sepsis 3 and SOFA scoring.
This brings us to arguably the most scrutinized diagnosis in all of healthcare, sepsis. Since 2016, the medical community has shifted to the Sepsis 3 consensus. Under this new definition, sepsis isn't just, an infection with a fever. It is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. To objectively prove this life-threatening dysfunction to an auditor, the patient's medical record must show an acute increase of greater than 2 points on the SOFA scale. That's the Sequential Organ Failure Assessment.
So how do we actually prove that 2-point shift? Act as a senior auditor with me for a second and look at how we measure this. We objectively measure multi-organ involvement across 6 specific systems. We look at the respiratory system using the PF ratio, coagulation through platelet counts, hepatic function via bilirubin, cardiovascular through the mean arterial pressure, or MAP, neurologic status using the Glasgow Coma Scale, and renal function by tracking creatinine or urine output. The moment a doctor writes sepsis, you need to mentally pull up the scorecard and start calculating.
Now, a crucial point here is distinguishing severity, especially when we move from sepsis to septic shock. Under Sepsis 3, septic shock is defined by persisting hypotension that requires IV vasopressors to maintain a MAP over 65 and a serum lactate strictly greater than 2 millimoles per liter despite adequate fluid resuscitation. It is so vital to distinguish this hyperlactatemia, where lactate is just over 2, from general lactic acidosis, which is typically over 4. This specific lactate threshold is a favorite, and I mean favorite, target for auditors looking to downgrade a septic shock DRG.
Let's dive into Section 3, Clinical Scenarios and Baselines.
Time to apply these rules to actual, messy, real-world patient charts. I want to pose a question to you. How do we calculate an acute SOFA shift for a patient who already has failing organs, right? Pre-existing chronic illnesses make our jobs as clinical investigators a whole lot messier. Imagine a 65-year-old male with a history of diabetes, hypertension, and chronic kidney disease. He comes in with a productive cough, fever, left chest pain. His blood pressure is tanking at 80/50, he has a GCS of 13, and his oxygen saturation is sitting at 86%. Imaging shows a left lower lobe consolidation, so clearly pneumonia. But how do we score him when his baseline creatinine from his CKD is already sitting at 1.8?
Well, establishing baseline clinical info is absolutely mandatory. In our 65-year-old male's case, his baseline creatinine is 1.8. During admission, he's placed on dopamine, weaned off after an hour, and his creatinine peaks at 2.4.
Because we account for his baseline, that acute bump combined with his respiratory drop, alternantal status, and low blood pressure yields an acute SOFA score shift well over 2 points. Actually, it lands around a 7. True sepsis is clinically validated here, but we have to carefully evaluate if true septic shock criteria are met given the rapid fluid responsiveness and transient vasopressor use. Now contrast that with an over-documentation scenario. Picture a 35-year-old female with an E. coli UTI. She has a fever and burning urination. Her presenting blood pressure is 90/60, but it resolves immediately after a liter of normal saline. Her lactate's perfectly normal, under 2. Yet the history and physical document sepsis with UTI, septic shock, and the discharge summary says urosepsis. If you calculate her SOFA score, it's a 1. That is less than 2. Sepsis and septic shock are clinically non-evident here. The documentation creates massive audit vulnerability, plus urosepsis is just a non-specific clinical term anyway. You must always check the baseline and calculate the raw score yourself.
Now, what's really interesting here is how specific circumstances can change the coding logic entirely. Let's look at a specific AHA coding clinic case study. We have a 24-year-old postpartum patient presenting with shortness of breath and a fever due to postpartum sepsis and a localized urinary tract infection. She had a spontaneous vaginal delivery about a week ago.
If we break down the exact coding for this, you'd assign 098.83 for maternal infectious disease complicating the purpurium, A41.9 for unspecified sepsis, and 086.20 for the UTI. But there is a massive pitfall you need to avoid. Assigning code 085 for puerperal sepsis is completely inappropriate in this case. Why? Because puerperal sepsis explicitly implies an infection of the genital tract, not the urinary tract. This brilliantly illustrates why clinical specificity is paramount. One wrong digit based on a slight anatomical misunderstanding leaves your facility wide open to a huge audit clawback.
Section 4. CDI queries and audit defense.
Think back to that over-documentation scenario we just talked about. The 35-year-old female with a UTI and a SOFA score of 1 where the doctor incorrectly wrote septic shock. You can't just silently delete the code, but you also can't just ignore the glaring clinical mismatch. So, here's what we do. Step 1. Identify that the documented diagnosis is unsupported by the clinical indicators because the SOFA is less than 2 and the lactate is normal. Step 2. Formulate a compliant, non-leading query to the provider, presenting the objective lab values and asking for clinical clarification. Step 3. If it remains unresolved, you address this through your facility's official escalation process. You absolutely must query when infection sources are unclear, or when the clinical picture just doesn't match the heavy-hitting diagnosis.
And I need to issue a very strong warning right here. If you are assigning severe sepsis, code R65.20, it requires explicitly documented linkage by the provider. You cannot just assume the acute kidney injury was caused by the sepsis. Payer auditors will deny your claims, arguing that the organ dysfunction was caused merely by the localized infection, like the UTI, and not systemic sepsis, unless the doctor explicitly links them in the chart. You have to query for that linkage if it's missing. Let's also briefly highlight a major edge case we see today, sequencing COVID-19 versus sepsis. Usually when a patient has sepsis and a localized infection, sepsis is sequenced first. However, the principal diagnosis for a patient presenting with both COVID and sepsis depends entirely on the specific circumstances and the primary focus of the admission. It's not a blanket rule. It requires careful, individualized chart review, unlike your standard localized infections. So I want to leave you with a final, provocative thought to take back to your daily workflow. Are your raw clinical indicators truly defending your documented diagnoses, or are you just hoping the auditor doesn't look too closely at the lab results? It is time to close the gap between narrative and data. Stay tuned for Part 12, where we unpack the official ICD-10 CM coding guidelines for sepsis, severe sepsis, and septic shock. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.